acute severe respiratory failure, and provision of intensive care was done before there was any drug available for these patients, as you know, in the spring of 2021. And despite of that, 20% of our ventilated patients died and 80% survived intensive care. So we think we did pretty well, actually. The thing is that during the last 10 years, we have had a collaboration with Per Olav and the Magic Foundation through our Nordic umbrella organization, which consists of anesthesia societies in Norway, Denmark, Iceland, Sweden, and Finland. And we issued guidelines for mechanical ventilation in patients with acute respiratory distress syndrome in 2015 after a slow start. And then several people in these Nordic countries have gone on to collaborate internationally. And the most prominent partners are Morten Nylander Møller and Anders Perner in Copenhagen, who represent the Nordic countries very well, I think. Now, before a single patient with coronavirus-induced acute respiratory failure was admitted to any Norwegian hospital, we requested from the Norwegian Directorate of Health that they endorse the international and Nordic guidelines on the management of acute respiratory failure. Because these are excellent guidelines. They are based on the GRADE system. They are trustworthy. They are of increasingly good quality, and they're roughly similar. And the initial response from the Director of Health was positive. They wanted to look at this, but then everything went off-grid. The Norwegian Parliament issued money that were to be directed to the Magic Foundation and to the World Health Organization, roughly €1 million. And I believe that some of these money were transferred to the WHO, but nothing was received by the Magic Foundation. So frankly, as a clinician who cares for desperately ill coronavirus patients, I'm a bit disappointed. We have here an environment in Norway which has made it to the top of the hierarchy in the provision of evidence-based guidelines, and who have been a trustworthy partner for the British Medical Journal, for NICE in the UK, and for WHO. And it seems that our local government here in Norway are frankly unappreciative of this. I find it quite scandalous, actually. I know this is one-sided. I know it's my perspective, but there you go. So that's my answer.
So one of the concerns we do have is that there's no true coordinated initiative to create guidelines across healthcare that would meet these standards. And as you have seen, this is complex. So we do need to collaborate internationally, rather adapt. And we are a bit stuck. Here's another colleague, Espen Håvarsson, who's a rheumatologist, also doing research. You are also involved with a professional society. And what are your thoughts?
Can I reply to you?
Sure. Go ahead. Can you come up?
Because I guess that wants to talk about something else, right? My name is Michael Brettauer. I'm not representing the Directorate of Health. I completely agree with you about what you just said, and it's scandalous on behalf of Per and the group. But looking at it from a system level, I find it worrisome that an institution like the Directorate is making guidelines in the first place, Yoon. I think it should be up to you and the professional organizations and people like Magic to do that. So in a sense, I think it's great that they said no, except of the money part. Because, and I say that because it's a problematic that guidance and recommendations, which are merely subject matter, are issued by the same institution that gives us the money or doesn't give us the money. I'm not speaking of the money to Per, the money to the hospital, for example. That's a problem. So they should stay away from it. You should continue doing it.
Very quickly, they were asked to endorse the guidelines, not to do the work.
Yeah.
And apart from that, I agree.
You don't even should ask them to endorse. It's not their topic. They should stay away from it.
A controversial topic, but let's hear from Espen Håvarsson, also working in clinical practice with research.
Thank you, Per. And first of all, congratulations to you and Magic and to Lovisenberg for this wonderful collaboration, which I think will be very successful. I'm involved in guidelines both at the national level and international level. And in rheumatology for the last couple of decades, we have been lucky to have a lot of new pharmaceutical drugs coming along. And we do have very good treatment recommendations, but they're developed by different international organizations. And of course, they are using the old traditional way of doing it. It takes maybe 2, 3, 5 years between each recommendation. And as clinicians, we have a lot of new drugs that are not covered by these recommendations. So I'm absolutely certain that living guidelines is something for the future. And how do we implement it? I see that there are some obstacles or challenges that we need to overcome. And especially for some of these international organizations, they have member journals. And of course, these treatment recommendations are some of their major products. And also they're driving the impact factor of these journals. So I think sorting out that kind of challenges and how to deal with living guidelines, could they be part of these journals once a year or every other year or not at all? So I would like to hear some, maybe if you have some experience with dealing with those kind of organizations and living guidelines.
Thomas, do you want to comment? Thank you.
Although I work with Per and his team for a decade now, I'm not fully aware of the Norwegian complexities, so I will not comment on these. But a related topic, I think, is who is making the guideline. And I liked very much what you said, Janet. WHO is organizing, convening, but who is drafting the recommendation? You said it several times. The GDG, the panel members, the clinicians are writing the guideline. And to me, I've heard Janet say it many times when we collaborate. To me, this is very, very interesting because this is also our experience with the Rapid Recs. Rapid Recs are not, institutions, organizations. They gather people from different fields and expertise. And we try to empower those clinicians through the methodology to issue their recommendation. So I'm saying that as an open question, who is really writing the guideline? I think it should be those who are planning to use it. This is also why we partner with patients, is to have patients on board in the writing of the guideline. Then it's about the authority, like who is legitimate to issue the guideline, who is convening it, who is checking the methodology, the robustness, the trustworthiness of it, which is another issue. You cannot just have 3 clinicians gathering and writing a statement and say this is what you should do. There is, everything we advocate the methodology and the tools, but I find it reassuring that in essence, the ones who are drafting the recommendations are the ones who are planning to use it, both from the clinical and the patient perspective. I don't know if this is any helpful, but those are my thoughts.
Yeah, thank you, Thomas. And we still have time for more questions from you. I've been very patient. So if you want to say something, please come up and I'll give you the floor. I think to your point, Espen, and as you've heard today, repeatedly, living guidelines are an innovation. We are learning as we go. We're discussing here in Oslo how to improve. But I think it seems like this is feasible for other topics and already a living guideline for rheumatology drugs in MAGIC from Australia and Canada. So that's moving forward, but it's just underscores, and I think you've seen the complexity in how we deal with evidence, work with trialists, develop these recommendations and update frequently. We just have to collaborate internationally. And then it's this question of who would issue the recommendations, and WHO has a clear role. I think you see NICE in the UK, and then we have the Directorate of Health in different countries. I think there's actually a role for several, because the healthcare systems, those who actually are responsible also for to provide public care and have the resources to do so, we have to take into account cost effectiveness, for example, that we heard about in other issues. So I think, Espen, this is doable in your field, but when you come to the professional societies, and we now in MAGIC support 16 of the biggest societies in cardiology, nephrology, and diabetes, and what Thomas briefly pointed to, conflict of interest is still massive. How do you get the experts that actually do not take money from the industry? And what if they have traveled around the world in the conferences to state this is the best treatment? Well, we have so strict bars now for who we would want to include in panels like WHO, they could not be part of it. Again, in a small country like Norway, we have Anne Flem Jacobsen here, being part of our anti-traumatic guideline way back in MAGIC app. We were able to find experts without conflict of interest, but it's quite hard in a small country like Norway, because you really do need the best experts, right? And is it okay that they take money from the industry? Is it not? I think we've shown repeatedly in the Rapid Rex and with WHO that you can definitely find those experts that don't have ties to the industry. And I think we actually have to come to that level. Then, if you have an international guideline for rheumatology, adaptation, having the experts in Norway to go through this carefully, what does it mean for us, is important. Still, we should think about conflicts of interest. So there are challenges here that we are David, and you could imagine who's the Goliath there in terms of controlling how, for instance, drugs enter the market. Challenges, many of them. Any have a question for anyone here? Maybe on Zoom? Stein, is there anything more? I think you're all exhausted by now. Kat, please, Kat, go ahead.
And thanks, Per. I just wanted to say one brief thing. As head of education at the BMJ, which has the strictest exclusionary competing interest policy of any medical journal, I think we're frequently told, oh, you'll never find an expert in that field to write on that topic. Everybody is conflicted. Everyone has links with pharma. And it's just not true. I think with enough kind of commitment to the principle of independence and a focus on the evidence without undue influence by industry, it's perfectly possible. And I sort of really applaud all the work that you've done on that in MAGIC and with the WHO.
Thanks, Kat. Okay. Now you deserve a break. I hope to see you in Villa Viten, which is the yellow brick building, cute little building on the left before the main hospital. We have drinks and food for everyone. Just again to wrap this up, we are very excited to be now in a partnership with Lovisenberg. One of our goals would be to test these tools that Thomas showed. How do these guidelines work for frontline healthcare professionals, doctors, nurses, physiotherapists, even in discussions with patients? Can we do shared decision making? We have low health literacy in our community, and Anders and the research group is a great advocate to do research in that field. So it's kind of our optimal lab. And I think also we could help you both get access to better evidence and guidelines, even into the electronic health record, as this E3 project is all about, and quality improvements to really demonstrate that we can improve care, increase value, reduce waste. So we're optimistic as always. Most of all, thank you so much for coming and listening, both on Zoom and here, and hope to see you in Villa Viten. Thank you.
you.